Nations Foundation. It's so great to be with you here today, and we have a really exciting panel for you. As always, the last panel has to be the most exciting because everyone is starting to fade, and we're the only thing between you and a drink. So we need to keep it, Anyway, it's a real pleasure for me to be here with you today. Many of you might not know me, or many of you might know me from my previous life. I started the foundation about 2 months ago, and we actually do have a DC office. Someone was just asking me. There's a New York office and a DC office. I'm based here. But before that, I spent 5 years at the Department of State working on PEPFAR as the gender advisor. So coming at this from the HIV angle, and it's been fascinating to hear all the presentations this afternoon when I was able to join, and I look forward to hearing from our other speakers. I am not going to introduce all of them at length. You have their bios, so that should suffice. And why don't we just go ahead and get started on the presentations? We want to make sure we have room for questions, so we'll just jump in and start with Geeta Lal, who's the Senior Advisor for Strategic Partnerships, Human Resources for Health at UNFPA in New York. All yours.
Thank you. Good afternoon, everybody. I hope you're still awake. But nevertheless, it's been a very, very interesting morning and afternoon, and we've been hearing about the challenges, some of the programs, some of the lessons learned, and we realized that some of the key challenges facing midwifery. One is, of course, the issue of numbers. There's shortages. We need more health workers than we have. Second is about access to midwifery services. Third is about quality of care, because we don't have competent midwives. Even when we are producing midwives, they are not competent enough. And lastly, but not the least, as our esteemed speaker from the World Bank was talking about, retention, deployment, and distribution of midwives. They're focused in urban areas. They're not there in rural areas, and we were talking about strategies. And then somebody in the previous panel spoke about leveraging technology. And I just want to point out a few facts. One is that today, about 40% of the population is online, which translates into about 3 billion users of internet. There are about 7 billion mobile subscriptions currently, of which 3/4 are in the developing world. Okay? Broadband access is expanding rapidly. The cost of netbooks, tablets, laptops is decreasing at a phenomenal rate. You can no longer talk about it as being expensive. And frankly speaking, a laptop would be the cost of the midwifery books that we supply to a person in a school. So given these kind of figures, the question that arises is, of course, that we need to leverage technology. And that technology is also not an option. And keeping this in mind, just the way the world is moving, whether we like it or not, Facebook couldn't have been thought of a few years ago. The mobile penetration couldn't have been dreamt of a few years ago. UNFPA started with a partnership with JPIGO, WHO, and Intel, talking about public-private partnerships, in 2012. And we've come up with an innovative solution on multimedia e-learning. I'm going to show you a 3-minute film which talks about this partnership.
sorry, she hasn't finished the presentation.
Oh, so
We'll
sorry.
make sure it's available, yeah.
Yeah, this is, yeah. So the modules, these e-modules they're multimedia. And one thing I just want to highlight, 5 of these 9 modules are for midwives, and about 4 are for lower cadres of health workers. And today I'm really delighted and honored that part of the team that has developed these modules is present here, right here in this room. I'd like to acknowledge Peter Johnson, Catherine Carr, Leah Hart from Jepaigo. And they did an awesome job. And of course, we had these modules, 3 of these modules on preeclampsia, postpartum hemorrhage, and prolonged obstructed labor were also reviewed by WHO. And apart from that, we have a technical advisory group comprising the ICM, the International Council of Nurses, and FIGO that has reviewed all the midwifery modules. And they have really looked at each slide and gone into the content. So what did Intel provide? Intel gave us their platform, which is called the school platform, SKOOL, not to mix it with SCHOOL. The school platform, which provided an offline access to these modules. And that is what initially attracted us, that even if internet is not available in remote areas, we would be able to use the school platform. But that is also posing a few challenges as we speak. We have been so engaged in the development work that operationalization of these modules is still to go. Jepaigo has started operationalizing them in Ghana in collaboration with UNFPA, and it's working very well in 6 schools. And today I want to present yet another mobile learning system, which is fresh from the fresh from the shelf, fresh from the press. How to make it even simpler. Now, just the challenges that we have been facing is that, okay, it is offline, but where is the electricity? You need a systems administrator to track the results of the quizzes. Really how do we operationalize all this? And for instance, these modules would work fabulously on any desktop and a laptop, but then they do not work on Android devices. They do not work on Android devices, and they do not work on cheap netbooks. Tablets, on cheap tablets and mobile phones. So if we were to convert it, so the next level of innovation for these same modules would be that if we were to convert it into HTML and make them compatible with any device, then all we need to do is we need to preload them on a micro SD card, which fits into any mobile phone, and give it to a midwife at home, anywhere, without using her airtime. She can do the training at home. Okay? So, and these micro SD cards, like for instance, this is an $8 SD card. It has 16 GB. And this can take all the 8-9 modules. So that is one plan ahead. Like I said, these are just some new ideas that we are using this opportunity to share with you. The other is that in remote rural areas, it's easier. There's so many challenges. You think about one challenge and you'll find there are 500 challenges that are bogging you down. You name it, I think all of us know. So how do we, say there's no infrastructure? Okay, there would be some wall somewhere, right? So we have bought this projector. It costs $260. It is a very simple projector. It's a battery-operated projector. This can be charged with a $60 solar charger. Okay, and this is a cheap. I keep getting confused. Tablet. This is a tablet, and the cheap tablets today can be $150. So together, the whole thing is under $500. Okay. And I'm going to switch this on. So I've charged it fully. And let me start my laptop. Give me just 2 minutes, and I will stop after that. I should have logged on before. Okay, so I'm not using the internet. I've just downloaded, we've converted one module into HTML, which I want to show you.
I'm not sure people can see though.
No, I'll just turn
Oh,
it on. Just give me 1 second. I'm just coming to the right screen.
Okay.
And this is a family planning module. And I'm just going to stand up. I'm showing using this white wall. So imagine you're sitting in a rural area. You just have this. Can I have a remote mic, please?
Family planning empowers women to plan their pregnancies, determine the number
It won't
and
work on here.
spacing of their children, and to avoid unintended pregnancy.
So in a school, suppose
This
there's a tutor
module
who
is
wants
for
to
health
orient the
workers
students on these
who
e-modules,
counsel
who can then
clients
go
on
home
family
and
planning,
carry these and
provide
put them on any
short-term
cell phone.
methods, and refer
They can do the
clients
training
for
at leisure.
other
So this is
long-term
one of the family planning,
permanent
counseling, and counseling skills for low cadres of workers. And I'm just showing you.
After you finish this module, you will be able to counsel women and provide these methods. In this module, you will practice talking with women in a way that makes them comfortable and This e-learning
You can't hear,
module
right?
is based on the new online global training resource package for family planning.
Which is,
This training
I should have
resource
thought
package
of
is
getting
the
a
new global set of
speaker attachment to it.
tools
But
used for
this is just to
family
show you.
planning and education. The purpose of this module is to let you practice using the materials and counseling tools.
See, sorry. Yeah.
Now that you are aware of the importance of family planning, let's go back to the training resource package for family planning and review the 4 stages of family planning. In order to establish rapport with a client, you need to communicate with them in a certain manner. Let's go through this exercise to identify the right way of asking questions effectively. Now, try answering this one. Click each image. So I'm sure you aren't interested in hearing about hormonal methods.
This is just to give you a sense, that you also get a sense of what these modules are about, and that we just need to convert them into HTML, and that the system would be available, and to just indicate that there are cheaper solutions. Available, or that we can come up with jointly, with partners, but really operationalizing it and learning from our own mistakes and, the bottlenecks that we come, because one of the key things with any innovation is that it's likely to fail. It's something new, right? So, and if it is likely to fail, we have to find the next, so what is the best way of moving forward in really making it work. So I think I'm going to just stop there. I mean, I just wanted to give you a flavor of some of the things that UNFPA has been engaged in, and we look forward to working with all of you and with JPIGO and ICM and others in really operationalizing this and using it, to make it work, and using it for midwives and other frontline health workers. Thank you.
Thank you so much, Geeta. Okay, now we are going to move on to Suzanne, yeah? Suzanne Stalls, who's VP for Global Outreach at ACNM.
Okay. Okay. All right. Thanks. Thank you very much, Daniela. And I'd like to stop and just thank the Wilson Center and UNFPA for hosting this afternoon. I've been a midwife now for 30 years, and I never dreamed that within the course of my career we would see such a rising tide of midwifery. It's really thrilling. So I'm very happy to be here. And today I'm going to be talking to you about the Survive and Thrive Global Development Alliance. So the Survive and Thrive Global Development Alliance is a global development alliance, a public-private partnership. We've made mention of those a number of times throughout the day. And it's designed to harness the resources, the expertise, innovation, and experience of professional associations, the private sector, universities, and the U.S. government. So this GDA was launched in June of 2012 here in Washington during the meeting of A Promise Renewed, and it was kicked off with a speech by Hillary Rodham Clinton, then Secretary of State, who said, "None of us wants to live in a world where a child's life," and I want to say parenthetically, a mother's life, also comes down to the luck of the draw. Survive and Thrive will connect healthcare professionals with their counterparts in low and middle income countries so that they can share insights and strengthen the skills in caring for mothers, newborns, and young children. So who are we? These are the founding partners. It is subsequently enlarged significantly, and there's probably double the number of organizations, but the primary partners are the three professional associations, or three of the professional associations in the U.S. who deal with mothers and newborns: the American Academy of Pediatrics, American College of Obstetrics and Gynecologists, and also ACNM. And then Save the Children and JPIGO are also very instrumental in that they are often the partners through whom we work in country. USAID, Johnson & Johnson, and Laerdal are funding partners, and we greatly appreciate their support. So what do we want to achieve? Our mission is that we want to help mothers, newborns, and children survive and thrive. Our goal is to increase the utilization and impact of high-quality, high-impact maternal, newborn, and child health interventions in health facilities. So how do we do that? So our first objective is to support and sustain facility-based MNCH interventions with clinical competencies and training and quality improvement. And I want to just stop 1 minute and say, we're very aware that in order to really move the needle with maternal and newborn and child mortality, we have to address the community as well. But this is a specific, I flew in from India a couple of days ago, so I'm still not quite on the right time zone, specifically focused on facilities. And also, we've really begun to examine very closely how do we embed and link quality improvement with training. We've all been training for decades now. We've trained and trained and trained. We have had variable results. I mean, clearly we've had some impact. Maternal mortality has dropped dramatically, but we still have a long ways to go. And part of what we're really looking at is how do we create quality improvement that is individually based and facility based, so that it's not always a system that is superimposed from above. So that the objective number one, how do we propose to do that? We propose to do it by mobilizing and equipping members of professional associations to improve the quality. And this is really the key mechanism and vehicle by which we propose to bring about these implementations of high-impact interventions. And then lastly, another objective, oh goodness, is, I only have 3 minutes, I am going to have to talk fast, is to mobilize newly graduated clinicians to become that next generation of global health leaders. So our objective one, you can see these are the topics that we have in terms of providing support with those clinical interventions. Those are the mechanisms: advocacy, quality improvement, pre-service education. You can see that these are the things that that we use as tools to help implement those interventions. Objective number two is to harness the potential of the professional associations, and not only do we want to support the professional associations in gaining competency in implementing these interventions, but almost by default, what happens is you strengthen the professional association, and then in addition, we can provide support in organizational development so that the professional association, as we've said many times today, midwives can take their place at the table and really influence policy. And then lastly, nurturing the newly graduated clinicians with mentoring, training, twinning, so that they can take their place as those of us who've been at this for a while decide to retire. So how to survive and thrive spotlight midwifery. The activities are initiated through the support of the USAID mission in the country or another in-country platform. Many of the requests for the support that have come in for the GDA have been specifically clinical initiatives that are directed by midwives and or support of midwifery professional association strengthening. And I think one of the really interesting things that has come to the forefront with this initiative is that our partners, our professional association partners, are very important in terms of ACOG, in terms of AAP. But a lot of the requests that have come in for them, for example, have been, send us your expert on balloon tamponade, or send us your expert on kernicterus. And the requests that have come in for us have really reinforced for me the fact that as frontline health workers, we have the capacity and the opportunity and the ability to profoundly impact health system strengthening. We are the people who are there delivering the care day in and day out in so many of these countries. So just a couple of quick examples of how we've done that. I'd be happy to share more if people are interested when we're finished, but we've worked, for example, with the Association of Malawian Midwives, otherwise known as AMAMI. We supported AMAMI as they implemented HBB in 6 districts. We collaborated with them to develop a support and supervision system. We most recently helped support them as they facilitated an MTOT for essential care for every baby. And then in conjunction with ACOG and AAP, we developed a professional association strengthening, strengthening workshop. And it was for the midwives, the OBGYNs, and the pediatric societies. It was the first time they'd ever sat in a room together. We worked on leadership and management skills. It was incredibly inspirational, not only for us, but for the participants. And I want to just put a plug here for the market. We use that as a way of gaining a baseline assessment, and through, we plan to be back in another month, and we'll be able to assess kind of where we've gone from here in terms of organizational development. Another country where we've worked is Afghanistan. We assess the capacity of the Afghan Midwives Association to implement clinical initiatives and assess key clinical topics which could be embedded within a train-the-trainer model. We facilitated a competency-based MTOT, again, workshop on respectful care, identification and management of preeclampsia, eclampsia, and newborn care. And then we also supported a clinical teaching skills workshop, and the mentoring that we've been providing then since that time has been provided remotely. So that's just a brief kind of highlight of some of the activities that we've been engaged in, and we will continue to keep plugging away with this initiative. So thanks so much.
Excellent. Thank you so much, Suzanne. Moving on to Chunmei Lee, Senior Manager of Worldwide Corporate Contributions at Johnson & Johnson.
Thank you. Good afternoon, everyone. I would like to follow Suzanne and thank UNFPA and Wilson Center for having me here today. Thank you. Oh, I'm just going to use this one. So I'd like to start my presentation today with a story. I want you to remember these people's name. The baby's name is Michael. The mother's name is Proscia, and the midwife's name is Eva. And this picture was taken last year, 3 days after Michael was born. Michael was born not being able to breathe. And the doctor who delivered Michael basically claimed Michael is dead and left. And luckily, Eva was there. So Eva used the skills, the helping babies breathe skill, and was able to resuscitate Michael and saved his life. So Michael is alive today because there's a midwife there, not any midwife, but Eva there, who has the clinical skill to perform resuscitation, but also a midwife who has the courage and confidence to challenge the doctor's decision. So Michael is alive today also because there's equipment and medical supplies there that day and functioning. And Michael is there today because the hospital has running water. So all these things that ensured that both Portia and Michael has a healthy life. When women like Portia manage to travel miles away and to get to the clinic, and it is everybody's responsibility to make sure that the mother and the baby has the best service possible can be provided. And this requires everything from making sure that staff has the necessary skills and medical supplies are there, and there's running water, and then there's record keeping. Well, Johnson & Johnson has worked in many of these areas, and I was asked today to specifically focusing on our partnership in leadership development. So we did have a few more leadership programs, and we had a program with ICM in the past to develop young leaders' leadership skills. But today, I'm going to talk about a leadership program and partnership with Sigma Tau International. I realized that, actually, I'm going to go back. When I look at a room, there are many leaders here. You're all leaders. Francis, Luke, Susan, at one point, you're all a clinician. You work in the clinics, and you become a leader today. I want you to think about your journey and the people that influenced you. If you were to have a conversation with your younger self, what would that conversation be? And what the single piece of advice would you give your younger self? So Sigma Tau is, according to Wikipedia, the second largest nursing organization. So they have, it's a nursing organization. They do have a focus on midwifery. And the Johnson & Johnson partnership with Sigma Tau started back in 2002 in the United States on Maternal Child Health Nursing Leadership Academy. The goal of this partnership is to improve maternal and child health through the following three areas. One is to increase leadership competency of individual staff, and the second is maternal and child projects that are implemented during this program. And the third one is changes in the practice in the community. I'll talk more about these. Here is the leadership journey. Started from the very bottom here. Participants will apply to the program with a project, with a maternal child health project, and that's one criteria. And the second criteria is that the project has to be interdisciplinary. So we talked about that earlier today, and whoever, the nurse who wants to participate in this program and needs to apply with a project. And once they're accepted, they will be paired with a senior mentor and a STTI, Sigma Tau's faculty member. And then they will go on to a leadership workshop. And this is an 18-month period time, and they will implement that specific project in the facility. And through the 18-month period of time, and the mentor and the faculty member will help this mentee and solve the problems. And then at the end of the program, they will have the second leadership workshop. And in the end, there will be knowledge and experience sharing in the community, and everybody will learn each other's learning. This is the leadership practice inventory. It's a standard evaluation tool for leadership. So it includes the following 5 areas. Modeling the way, meaning leading by example. So I think that's pretty clear. The second is inspire shared vision. This means like you could think that this nurse, this midwife needs to lead an interdisciplinary team. So she needs to inspire others to share her vision, share her idea. And the third one is challenge the process, which is the case with Eva. If Eva didn't challenge the process, and baby Michael will end up in the refrigerator. Fortunately, he's alive. The fourth one is empower others to act. So one person can't move a mountain, but if you can empower others, and then you will see the change. And the last one is encourage to hear. This means that positive enforcement. As a leader, you need to constantly encourage others. So these are the 5 areas that all the participants will be evaluated throughout the program. At the beginning, and in the midterm, and at the end term, they will be evaluated based on these 5 areas. Theory of change. So through the program delivery, these projects, these individual leadership development plan, and 3 minutes, okay. So we see changes in the individual confidence and the facility quality of care, and also patient knowledge, because some of these projects are about patient education and patient support. And through the sharing, and you see communities replicate and adopt the other projects that other people has done. And then at the end, they will see improved maternal and child health outcome. So I'm going to end my talk today with asking you to think about, when you think about quality of care, what's the first thing that you come to your mind? And if you talk to different people, probably you get different answers. But the common thread is that quality of care is about meeting the needs of a mother and a child. So quality of care is about meeting the mother, the need of the mother and her child. And this is something that we need to keep in mind as we do our work. And I'm sure sorry, I lost my thought there for a moment. So midwives are at the best position to identify these needs, the needs of mothers and child, and identify the solutions and also implement them. So with a little bit of help, the midwives can save more lives of mothers and babies. Thank you.
Okay, so now we have one last presenter, and I know she didn't get a lot of sleep last night because her plane was delayed, so we will bear with her as well. And that is Jessica Koval, Program Manager, International Programs at Direct Relief. Thanks for making it all the way here.
Thank you. I'd also like to follow my colleagues and thank the Wilson Center for hosting this event, and also UNFPA and Midwives for All. Today there's been a lot of comments about the lack of supplies and inadequate working environments for midwives. I'll speak briefly about how Direct Relief is mobilizing medical resources to enable midwives to provide safe and quality care to the women that they serve. So Direct Relief is a nonprofit NGO, and our focus is on strengthening fragile health systems that serve people who are poor by ensuring healthcare providers in impoverished communities are able to maintain, improve, and expand health services to the people regardless of their ability to pay. Direct Relief's core programs focus on maternal and child health and represent an effort to reduce the burden of maternal and newborn mortality. With a focus on women and children, Direct Relief provides prenatal care incentives for pregnant mothers, support for midwives, including supplies, and also cash grants for midwifery training. And in addition to that, we also work to upgrade facilities, emergency obstetrics care capacity. The reality is there's a global shortage of essential medical commodities. The conditions that women face giving birth throughout the world can be very poor, including not even having a proper bed to deliver on. It's even less likely that more important medical commodities such as essential sanitary items, personal protective equipment, and essential medicines will be available. This means that midwives working in impoverished communities are often posted to facilities that lack basic medicines, supplies, and equipment that enable them to do their work. The critical shortage of essential medical commodities for maternal and child health has been one of the contributing factors hindering progress in reducing maternal and newborn mortality. Many groups are developing technical and pharmaceutical innovations to address specific causes of maternal and newborn mortality, but not all of these essential materials are available to those who need them. Innovative steps must be taken to provide these items to healthcare providers and facilities all around the world, and this is where Direct Relief's strength comes to bear. We've been mobilizing medical material resources since 1948 through partnerships we have developed in more than 97 countries. And we've been working with midwives for many years. To address the lack of available supplies for midwives to provide safe deliveries, Direct Relief partnered with the International Confederation of Midwives to develop a standardized midwife kit for facility-based deliveries. In developing this kit, we focused on the most common causes of maternal mortality, such as postpartum hemorrhage, eclampsia, sepsis, and other direct causes such as obstructed labor. And we also examined the causes of newborn mortality such as preterm birth complications, sepsis, congenital abnormalities, and tetanus. And from this, we developed the contents of the kit, which include essential interventions to prevent complications and reduce maternal and newborn mortality. One of them being misoprostol to prevent and manage postpartum hemorrhage, and chlorhexidine for hygienic cord care to prevent sepsis. The midwife kit also includes other essential interventions and commodities such as medical instruments, consumables, and sanitary products to enable safe births and prevent the most common causes of maternal and newborn mortality. All the interventions I just mentioned are combined to create the kit, and here's an example of what it looks like. This midwife kit has the potential to reduce 62% of maternal and newborn deaths. Now, our work would not be possible without the support of our partners in countries all around the world. It is our partners that go the last mile to get supplies and medicines to people and places that need it most. Direct Relief has most recently provided midwife kits to graduates of midwifery training programs in Sierra Leone and Somaliland. In addition, we are supporting 35 midwife-led maternity clinics in Typhoon Haiyan-affected regions in the Philippines. Many of these facilities were severely damaged after the storm, and midwives managing them lost everything. In addition to this, we have focused on providing support to midwives in Sierra Leone and Liberia as an effort to strengthen the fragile health system while it's recovering from the tragic Ebola crisis. We are currently seeking new partners to scale up our support for midwives. And I will leave you with a quote from an alumni of the McKinney School of Midwifery in Sierra Leone, which has received midwife kits from Direct Relief for the last 2 years. You don't send a farmer to the field without a hoe, and you can't send a midwife to the community without the tools she needs. If you'd like to learn more about this program, you can visit our website at directrelief.org, or you can email me with questions. Thank you so much.
Okay, thank you so much for that. Great presentations. I want to say a few words before we open it up to questions. So start thinking about your questions. Um, it's really interesting to hear all of these various presentations, and I'm so excited to see that as part of the agenda, we are having this conversation about public-private partnerships and innovation. And I think it's especially important given the year we're in. So we are in a moment right now where, as a global community, we're rethinking our goals. And so we're moving away from the MDGs to the SDGs, the Sustainable Development Goals, and in September those will be adopted. And there's a desire to really think about how do the issues of maternal and newborn child health influence that agenda, as well as how to finance that agenda. And I think an interesting, evolution, and I'm glad, Francis, you talked about this a little earlier on the previous panel. What is the role of midwifery in terms of not only how you finance that response, but also as you think about these multi-stakeholder partnerships? We saw several examples here where you really have the private sector, and it's more than just a public-private partnerships. We moved away from that idea to really think about private sector, governments, bilateral donors, civil society, associations. How do all of those come together to help finance that response? And so, in Addis in July, we'll be having the financing for development, big meeting 10 years after Monterey. So I think there are a lot of conversations this year about what is the role of different kinds of interventions and innovation in terms of getting us to where we want to be. And as we think about the different health professionals that need to be part of that response, I think we're seeing an opportunity really to highlight the role of midwives and how that contributes to those goals, as well as how that saves people money, which is always important given restricted resources in our global challenges. So with that, why don't we take just a few questions? I'm going to take 3 questions at a time and then ask the panel to respond. So when you ask your question, if you could just say who you are, remind us the organization you work for, and then ask your question. We'll start in the back over there. Way in the back. Do you have a microphone? And also, if there's a specific person on the panel you want to respond, let us know. Otherwise, we'll keep it broad.
Okay. Hello, everyone. My name is Saida Lara. I used to be an intern at ICM, and I'm a midwife from Peru. My question is, now that we're talking about interventions in midwifery, I would like to know if any of you or any other of the stakeholders in this room have ever thought of involving midwives in sex education teaching at schools, because I believe that prevention is one of the most important things to reduce all these figures we have. And in Peru, I'm actually trying to initiate that, midwives teaching at schools, especially high schools. I just wanted to know if you have something like that in mind. Thank you.
We had another one there and then over here.
Thank you very much. Thanks to the panelists. I think it was a very interesting presentation on innovation. But I'd like to ask the presenter from Johnson & Johnson about midwifery leadership training. I think it is very critical. It is very critical. And I want to ask you, can you tell us about your evaluation? Any evaluation was done in relation to midwifery training and your findings as it relates to strengthening of midwifery? Thank you.
All right, and we had one last question over here.
Hi, I'm Rima Jolove from the Maternal Health Task Force. Actually, my question mirrors very much the last one. I'm interested in the needs assessment process. I'm interested to see how broad the range of different kinds of innovations, from very high tech to very low tech, and then organizational development, they're just all over the map. So I'm interested in the needs assessment process and how stakeholders drive those innovations. And then I'm also interested in the monitoring and evaluation framework and how, and whether any of you are applying sort of the study designs of implementation research or randomization, or how are you looking to see the impact of these, the impact of your innovations?
Excellent. Let's get some answers and then we'll go around for more questions. So who would like to jump in? Who would like to volunteer?
I can start. Since there's a question directly to the leadership program, thank you for that question. And so it's a great question. And right now, the program's evaluation really just focus on the leadership skills of the participants. So like I presented, and they use the standard leadership evaluation tool. And in terms of the health outcome, and we don't have a random controlled study about it, but we do have a lot of anecdotal stories where a project is being replicated in other hospitals, and also a participant who was just a midwife and then now become a district officer. So like a career change in the, it's a good thing or bad thing, I don't know, but it is anecdotal stories. I would also like to focus on, make a comment about the evaluation on innovation. And I do know that there is a random controlled study about a app-based e-learning program happening in Ethiopia. And the initial finding is very promising. I don't have it in front of me because I was not supposed to talk about that, but I'm happy to share via email if people are interested.
Hi. Can you hear me? Yes. Okay. So I'm going to respond to the first question and the third question. And the first question I want to respond to simply because you've touched on a topic that's near and dear to my heart, which is midwives feeling empowered enough and informed enough and engaged enough to move into their communities and begin to provide the support, the education, and the knowledge and skills that we really have as a result of both being trained and then practicing for a number of years. So I guess this is a somewhat roundabout answer, but in response to your question, the midwife from Peru, I think that that's one of the things that I really enjoy in working with the GDA is working with both the individual midwife and with the professional association so that they come to see themselves as capable of providing that kind of leadership and providing that kind of support. So I feel like it's a dual purpose. You can work with the individual, you can work with the professional association. And then in response to Rima's question, in terms of the GDA, one of the things that I always think about with the GDA, so we've been in existence now for 2.5+ years, and I think of a quote that I heard Obama say one time about democracy and that it was a messy process. Well, public-private partnerships are a messy process. There's just no two ways about it. And does that detract from their inherent value? No, not at all. But I think we have to have a fair, degree of comfort with messiness and uncertainty as we kind of slog our way through trying to shape what needs to be shaped. So we've really struggled with the issue of monitoring and evaluation and looking at outcomes. And what I'm going to say to you is I think we're finally at the point where we have enough framework, enough structure, enough impetus that we can actually put into place, and we're working with May on that, to begin to evaluate some of what we're doing. But one of the things that's been very helpful, and I said this before, so I'll just mention it again, in terms of working with the professional association, the tools that ICM have been key in our ability to gain baseline understanding and then begin to move towards evaluation.
I'm going to respond briefly to the third question, Rima's question. One is about needs assessment that you asked. I think for instance, the UNFP ICM program, we've done so many needs assessments, over 30 plus needs assessments and gap analyses. And how this thought about developing e-learning emerged it actually came out of those needs assessments. Because even blindly, even if you don't do a needs assessment in a country now, you know that there are no tutors. They lack, clinical skills is a key issue. Teaching skills is a problem. Mentorship, supportive supervision. Particularly clinical skills training is a huge gap. So that's why finding ways, and the way the world is headed, whether we like it or not, like I kept saying, technology today is not an option anymore. Because if you don't do it, there are already things mushrooming up. There would be, I'm sure that, okay, I'm presenting here, but there would be at least 100 similar, or along these lines, the thinking is already happening in various parts of the world, developed and developing both. So it really, there was an element of needs assessment that fed into this particular innovation. Talking about evaluation, that is something which we are taking seriously, and we're going to start serious discussion with JPIGO on how to develop an evaluation framework for the e-learning training. We started with 2 pilots. One was in Ghana and one was in Bangladesh. Bangladesh is still plodding along, struggling for reasons beyond our control. Ghana, JPIGO has already implemented in 6 schools, and it's going well. There's been some learning, out there. And there are other countries, like particularly the GFF countries that we are planning to target now: Kenya, Tanzania, Ethiopia, and Zambia. These are the 4 countries that have expressed strong interest, very, very strong interest in the e-learning. Because what we did was we did induct all the midwives that we have who are staff. About 250 brief induction trainings on these e-modules have already been done. And they went back to the countries, and they collected a group of midwives from the schools, and they tested some of these modules with them. So the rough figure is about 300 people have seen and worked with these modules and gone through some of these modules. That is UNFPA. With JPIGO, I think it's about 1,000 plus, Leah, right? Yeah, she's shaking her head. So about 1,000 people have done these modules through JPIGO. So we are going to develop an evaluation framework, really see what was the learning. There are other evaluation studies. For instance, AMREF has been, Kenya is using an AMREF e-learning model for nursing training. It's countrywide. And they did an evaluation which is highly, highly positive. So there are people who have launched e-learning and have done evaluations and find that it works. But specifically for this blended learning kind of a model, we do need to do an evaluation, and we are working on it.
All right. I'm just going to say something. I'm so excited that question came up. I always used to say when I was in PEPFAR that we have a lot more M than we have E. And we talk about M and E, and it's so important to really understand that, because just because it's new, it doesn't mean it works. And we need to understand what works in order to be able to scale that. So thanks for that question. Yes, we have 1, 2, and 3. Let's start on this side.
Well, I just want to comment and follow up a little bit on the e-learning that Gita has, I think, just talked about very well. But just a couple points of clarification and just words of maybe advice as one gets started. So I remember when Gita called us the first day and said, we need JPIGO to help us with designing these modules, and I said, only if it can be competency-based. So we did a study a couple of years ago looking at what constituted effective learning. And one of the things that we found out that was, I think, makes sense in retrospect, but was kind of profound to me at the time, was that if you put a bad technique onto a good media, you'll get a bad result. So a lot of what we see out there with e-learning is just e-reading. Mm-hmm. And we know that reading's not effective in terms of changing practice behavior. So we are trying to work with UNFP to make these as competency-based as possible, as interactive with learners as possible. That said, I wanted to say this represents 9 high-quality modules that have been globally endorsed, but they're still just 9 lessons. Okay, and 9 lessons don't make a curriculum, they don't make e-learning. And the last thing I'm going to say is we're in Ghana, where we have really heavily invested in this. I was with my country director from Ghana last week, and somebody said, is this a good idea? And it was a very frank question, and she said, yes, it's a good idea, but not because it's cheaper, not because it's going to be a shortcut and make your life easier. She said, in fact, she would recommend doing it because it makes education and learning more accessible. It opens up a lot of doors that aren't currently open. All the things that Gita said about faculty shortages, those things are all true. But she said, unless you have the political will at the outset, unless you're willing to invest in all of the systems that are required in order to really make e-learning work and take it to scale, said, don't start. Because it is, we should be doing it for a lot of reasons, but it's not something that's simple, easy, and is going to make our, just allow us to cut corners.
I'm Marian Suba from Chicago. For the team, thank you very much. And it's very exciting, all of the innovations. I wanted to know if you could make some comments on innovations in terms of preparing faculty. Like we talk about the leadership, if people know about those kind of programs of preparing faculty to be responsive, especially using those things to learn or teach. And also for the kid, the supplies. Like in Liberia, we have these 3 things that we talk about. We're saying you would need to have the right knowledge and skills that we talk about in Chicago, the right things to work with, and the right motivation. And so that's very important. But I also want to look at it in terms of the clinical sites for the students. How can we also help with that? Thank you.
Thank you. Thanks for the great presentations. I'm Roger Mark D'Souza from the Wilson Center. And I was very glad with your comment just now, because you sort of ended your comment by saying, unless we have political will. And I'm reflecting on our discussions during the course of the day, and I think we've had some examples of good political will, but a number of instances where the absence of political will is a real obstacle. And so, I'm thinking a little bit about that. I'm thinking of these innovations and scaling up. So I'd like to hear a little bit more about, if you're looking at different scales, what are some of the success stories you have had in overcoming when there's a lack of political will, and what are the opportunities to promote South-to-South collaboration and learning in that context?
Great. Okay, let's do a round of answers, and let's do volunteers again.
I'll just comment on the scale. I don't know if it's an answer. So at J&J, and we had actually discussion about what do we mean by scale. You can have program running in 10 countries, but in each country you have 1 district, 2 districts, 3 districts. Is that a scale? Or you can train, let's say, 1,000 or 100 house workers in 1 district. Is that a scale? So what do we mean by scale? So I guess that's a question to the audience to think about. So back to you. So for us, and we talked about scale, and then we kind of step back and looking at, okay, if a program making a difference in the facility, and every baby that was going to be born, every woman who is going to deliver in that facility is going to be able to benefit from it. And it could be 100 a year, 200 a year, we don't know. For us, we can call it that's a scale, because you're scaling in a setting, in the catchment area. Otherwise, we have limited resource. We're not going to be able to support everybody everywhere. We have to focus our resource. And I think the question about scale has to link back to the resource where it makes sense. So that's just a comment. Anybody else?
I'd like to respond to Marion's question about leadership in terms of developing faculty. And this is not an answer, these are just comments and thoughts. But I think one of the challenges when you move into this sort of arena is it does become so much more difficult to quantify the effects or quantify the impact. And so I feel to a certain extent that there does ultimately have to be a bit of a leap of faith or some political will whereby we say we value leadership. And so therefore, by valuing leadership, we will place emphasis on it regardless of whether we are able to give a quantifiable number to the outcome. Because how do you measure leadership? Sigma Theta Tau has looked at some of the metrics for evaluating their program. And I guess my question is, and I've looked at them and they look good, but ultimately, what are we after when when we talk about leadership? What we're after is someone who's inspired and inspiring, someone who has a vision and is able to communicate that to other people. And I'm not sure ultimately that that's something that we can put hard numbers to. So I would encourage us as we move forward into this next era of sustainable development goals that we realize that there is an enormous psychosocial gender component to all of what we're trying to achieve, and that we may not always be able to affix hard numbers to it. So, and I'm just as data-driven and evidence-based as the next person, but I think that there is there's certain components that we're going to have to be willing to say we're committed to, regardless of how we're able to attest to their value.
I'd like to respond briefly to the question about political will. That, as we all know, is absolutely key. If you don't have political will, you can only go this far and not beyond. And as I think Laura mentioned earlier in an earlier session, that we have to situate most of our programs within the national framework and national strategies and national human resources for health strategies. And that's what we are trying to do. Say for e-learning also, we do see whether the country has an e-learning strategy. What is the e-learning goal and what are their, like for instance, why we chose Bangladesh was they have a 2020 vision which says that whole of Bangladesh will be digitized by the year 2020. So before we even did anything, we got the project proposal approved by the Prime Minister's office. So it is in the HNPSP, Health, Nutrition and Population Sector Plan of the government of Bangladesh, this e-learning. And they helped select the districts that these are the 2 pilot districts where this program is going to be launched. So that otherwise, we might be shooting ourselves in the foot if we do not have the government engaged with us. And the other thing why we chose, for instance, Bangladesh was that we also realized that World Bank had distributed a large number of tablets to health workers. Now, what we didn't realize, again, and I'm acknowledging our mistake, was that some of those tablets, our modules will not work on those tablets because, the platform that we are using, it's not compatible with those tablets. However, the moment we can spend a little bit more money and convert them into HTML, all the workers who already have those tablets, it'll start working on those. So it's, it's really important. Same thing is, today, what we are seeing, and there are so many examples. Some of our children, and those of us who are older than that, our grandchildren, will not be carrying school bags in the next 5 years. They will not be carrying school bags. They will be carrying this. This will have their entire curriculum. So the entire generation of people who are coming out of school will be technology literate. They will be technology literate. That's why I keep making the case, whether we like it or not. Today, it is not an option today. Because if we don't do it, somebody else will do it. Somebody else is already doing it. Let's capitalize on it. It is a cheap solution. It's like today, electricity cost, is giving us $500 bill per month. All of us in this northeast corridor with the snowstorms, etc. But 10 years down the road, when solar becomes viable, we won't even think about running the air conditioner around the clock or what have you. So it's really harnessing that, getting people to understand and joining forces, partnerships again. and really seeing, getting all and another thing that the colleagues we said we have to have a project management approach. Just technical skills does not work. You need a hardcore program manager, you need a strong coordinator, you need all the elements. It's exactly like in a government. Health, Ministry of Health cannot work alone. You have to have the Ministry of Finance. You have to have Ministry of Education. You need a multi-sectoral approach. Otherwise, half of projects are falling through the cracks. So that's just my last part.
Okay, so we're going to take I was told I can go a couple of minutes over because the closing is going to be quick. So are there any burning questions? This will be our last opportunity. Okay, there's a burning question over there.
Not a burning question, but perhaps just a response to Marianne. And I don't know if Francis or Deborah would want to follow up. Marianne did ask about what are we doing to strengthen tutors training. And there's Latin American, Caribbean competency-based education training that has been scaled up and doing excellently. Perhaps Francis would want to just continue, or Deborah, yes.
Yeah, mentorship trainings, teaching skills trainings.
Does Deborah want to say something? Where is she? Okay, there she is.
In the region, in the Caribbean, we're working on introducing the CB, the competency-based education training. So we've done training of trainers that's been expanded. I think, is it 6 countries, Mandy? 7? Oh, yes, sorry, Catherine. Yes, 7 countries, and it's been very successful with the support of the new and evolved MCHIP. Sorry, I can't remember them.
CSP.
Okay. Any last thoughts from our presenters? So, yeah, please go ahead.
I would just say whatever we do, and it needs to be locally owned. And so that speaks back to the scaling and sustainability. And that's the approach that we at Johnson & Johnson take with all of our programs and with Survive and Thrive. And then we emphasize on the locally owned and local buying.
Okay, so I'm going to close with one of my favorite quotes. No, we're not going to. Francis is going to say something. Go ahead.
Do you want to use Francis? Take this.
Thank you. I just wanted to use this opportunity to remind and to invite people. On the 5th of May is International Day of the Midwife, and ICM has been running this since 1992. And this year our theme is Midwives for a Better Tomorrow. And I think it really fitted with all the discussions that we've had today. So please go to our website and join up and help us to celebrate and highlight the role of midwives in saving women's and babies' lives. Thank you.
Okay, so maybe now I'll do that. No, Suzanne said something about the gender issue, and you just brought up the May 5th date. There's a quote by Eleanor Roosevelt. It's one of my favorite quotes, and every time I have the privilege of going out to different countries and really seeing midwives in action, it reminds me of this quote, and that is that women are a lot like tea bags. You only know how strong they are once you put them in hot water. And so there really are amazing women doing amazing work all over the globe. And so it's a privilege to be here with you today. Thank you to UNFPA, the Wilson Center, and our great presenters.
I do promise you a quick closing, but before I get to that, Francis did just reference the ICM's website. So we have one last quick video. They've all been very moving. I'm sure we all agree to that. So a quick video, and then we'll do a quick closing, and then we will have some wine. Because I heard fried food didn't work on this crowd, so wine will.
I have a kind and caring midwife who's helping and guiding me through my pregnancy, keeping me and my baby healthy, and who'll be the comforting voice at my side when I give birth.
As a midwife, I want to have the right training and support to give women what they want, to be valued in what I do, and to be able to share my expertise when and where it's needed.
I just want a good midwife.
Around the world, 1 in 3 women give birth without expert help, while the equivalent of 2 jumbo jets full of women die in childbirth every day, leaving their families to cope with no mother. This leads to poverty, distress, and further cost in supporting those left behind. It's a downward spiral. In many countries, some women report that they are traumatized after the birth of their baby, physically, psychologically, and this impacts on the whole family. And sadly, it's not just the shortage of professionals that is preventing women getting that expert care.
I've heard that in some countries, midwives can't practice because it's illegal or because their skills aren't respected. In some places, they can't do a good job because unnecessary and expensive medical procedures are used to avoid risks that simply aren't there.
I know that sometimes midwives are working under such pressure, they forget the importance of kindness and respect. They are let down by the system, and in turn, their lack of compassion fails both the system and the woman.
In my country, midwives can be cruel. One beat my sister because she cried out in pain.
Research shows that when midwives are supported with good regulation and education, and women have sensitive, skilled, and respected midwifery care throughout their pregnancy, both mother and baby are more likely to live. But it's not just about survival. A happy and positive birth is the start of an upward spiral that strengthens the whole family to the benefit of everyone. Having access to a skilled and caring birth attendant is crucial. The evidence suggests that midwife-led care saves lives, reduces unnecessary intervention, and saves money. We must have more educated midwives who are able to be with women wherever they are needed. They should be valued and respected and enabled to show their kindness and dedication.
I can help by sharing my positive experiences. I can talk to the policymakers to help them understand that every woman deserves the best possible journey into motherhood.
I can help by trying to change the system. I can encourage those who provide maternity services and midwifery education to understand my worth. And I can encourage my fellow midwives to practice their skills with warmth and humanity.
And you can help me. A better world starts with healthy families and strong relationships. So give me a good midwife and the birth I deserve.
So, as the day started, our colleague Katie from the Maternal Health Task Force joked with me and said tonight I'd probably fill out an application to be a midwife. And you know, you're almost right, except then I wouldn't have this really great job I have, which is to help organize panels and days such as this. We've heard reference throughout the day to other sessions we've had here. Many of you in the room have been on these panels, or your colleagues have, and so I'm tempted to look at the application tonight, but it's a difficult decision. So we have had a full day. I know when Roger Mark provided his introduction earlier, many hours ago at this point, he said that we were going to look at midwifery at a 360 angle, if that makes sense, or 360 degrees of midwifery. There we go. And I think we did that. You know, we started talking about how data can help highlight midwifery as a cost-effective solution to improving maternal and newborn health. We had country experiences further demonstrate such successes, and much of these successes can be contributed to major global midwifery initiatives that we heard about and the innovations that we've not only heard about but saw earlier on this whiteboard. So, I just want to encourage us to continue to foster partnerships and synergies around midwifery. We will do that downstairs for a bit over that wine and fried food that I keep talking about. Clearly, I'm hungry. But I do want to just take a few more minutes just thanking you for joining in this discussion and encourage you to continue to have the discussion. And you can do this by following us on our blog, on our website, through Facebook and Twitter. And so please join me in thanking all of our speakers, truly the experts. They're all very esteemed in the field. And also thanking our co-organizers, including Laura of UNFPA, who's going to officially close us out. But thank you. This wouldn't have been possible without all of you as well.
What a fantastic and intense day we had here in Washington, D.C., right? So, we are very happy that we brought Midwife to D.C. They were in D.C. as well, but I think that for us, it's very, very important to have gathered with all this group of people. I just wanted to tell you, as you have seen in one video, that we had an event in Geneva in the month of February, and now we have had this event here. And for those of you who perhaps have been don't have this historical perspective about the global discussions and conversations, this is, in my view, is very, very is a very amazing progress, because we have not had, these discussions on the granularities of midwife for so many times. So we are advancing. That means that it reflects what is happening in the countries. It's not that we are talking in the, and the participation of Ethiopia, the participation of Liberia, and the participation of Cameroon here, as well as the colleagues who couldn't make it here because of more, the visa situation, Afghanistan and South Sudan. That talks about how much progress we have done. And so I don't want to do a summary. We have had so many, words today, but I just want to tell you something. We talk about political will, coordination of partners, alignment of partners behind national structures and national plans. Midwife supported as part of the health team. Innovation, social entrepreneurship for midwives, evaluation, distribution of resources. But there was a question: are the midwives on the table? Are midwives at the table? Sorry. So we respond we respond with call the midwife. Okay. So let me thank you. I would like to ask and thank the co-organizer of this event, the Wilson Center and the government of Sweden. We also like to thank the Excellency, the Mr. Björn Liervall, the ambassador of Sweden to the United States. I think he has been amazing for coming here, taking the time to come here and open this symposium. I would like to thank also all the moderators. I'm not going to name all of them because they have been named several times. Also thank to all the presenters and the participants and guests, but also the communication team from the Wilson Center, UNFPA, and USAID that have been tweeting. Then we will check, how that went. And also, I want to thank also, all the technicians from the Wilson Center that had made this really possible. And, we had a great day here. The other thing I want to thank is all the other colleagues who were coordinating behind the scenes, were able to prepare this. Sandeep Bathala, again, Benjamin Deals from the Wilson Center, UNFPA DC office, Sarah Craven, and Rachel Monahan for the local coordination with the Wilson Center, then Mandy Lafleur in New York, and also the general coordination, Gita Lal, from our UNFPA midwifery program in New York. And also the team had, I think they deserve a great applause, round of applause, and so I close. So, call the midwife. Thanks.